Great. Well, thank you, everybody. And thanks for everybody here in person. We expect some more people to be coming through the door. So excuse anybody walking through the camera. And thank you to everybody attending virtually. We're excited that you're all joining us today to discuss a very important topic and really a project that was necessary to do. And can't say we're pleased with the project and what it shows. However, what it does put upon us is to get some reforms made to make sure that patients do benefit from 340B as the program intended. So I'm Kim Czubaruk. I'm Vice President of Policy with CancerCare. And we have our panelists here with me, and I'll just introduce myself a little bit about CancerCare, and then I'll turn it over to my fellow panelists. So for those of you not familiar with CancerCare, we're an 82-year-old organization, nonprofit organization, that empowers millions of people affected by cancer through free counseling, resource navigation, support groups, educational resources, advocacy, and direct financial assistance. Our oncology social workers improve the lives of people diagnosed with cancer, caregivers, survivors, and the bereaved by addressing their emotional, practical, and financial challenges. And just to give you a sense of the need out there and the amazing work that our organization and our social workers and resource navigators do, in 2025, the organization's master's level oncology social workers fielded nearly 1,000 calls and emails per week from cancer patients, caregivers, and family members throughout the country. We'd like to thank our sponsors. Without them, this research project and the important findings, both the data and the patient stories, could not have come about. So thank you. Before I turn it over to my fellow panelists, just a very quick explanation of how this project came to be is I was actually at a dinner with Robert about a year and a half ago now, maybe a little bit more, and was speaking about how people, patients with cancer and Medicaid sometimes have real challenges when they go to a hospital getting the care they need. Perhaps sometimes they're sent, they're triaged and or sent to a different hospital because of their Medicaid status. And that got us talking about the 340B and the need to make sure that this program, which is intended to benefit patients, indeed does benefit patients. And then we partnered with Pioneer Institute, asked them to help on the data analysis end of this, while CancerCare focused on putting a human face on 340B, so it didn't remain solely a discussion of numbers and economics on the back end. And with that, I will turn it over to my fellow panelists.
Thank you, Kim. And let me mention what a great partner CancerCare has been on this project. As Kim explained, the origin of this project is CancerCare started hearing anecdotal stories that lower income patients treated at 340B hospitals were not getting charity care, were not accepting Medicaid, and they were having trouble getting treated at 340B hospitals. And that's ironic because the whole purpose of the 340B program is supposed to be to stretch limited federal resources so that these lower income patients could be treated. What is 340B and where did it come from? It actually was an accident. It was a legislative fix. In 1990, Congress passed a best price statute that required drug manufacturers to give the best price to any private payer that they gave a drug to. And that price had to ripple through all 50 state Medicaid programs. It's called the best price program. The problem with that program is the Congress didn't see that there were many low-income, particularly clinics, that were treating lots of low-income patients who were getting voluntary deep discounts from manufacturers. And if those prices had to ripple through all 50 state Medicaid programs, these clinics became concerned that the prices were going to rise for them. So in 1992, at the clinic's behest, the Congress stepped in and created the 340B discount program. I want to mention that it wasn't envisioned that hospitals would be included in this program. The report language in the House bill says they want to stretch limited federal resources. And if you're stretching federal resources, it's not an entitlement. You're stretching resources for programs that have an appropriation, a specific appropriation. So this 340B program is sometimes described as a discount program that provides savings to covered entities. It's not a savings program. It's a revenue program, because under this program, hospitals in particular can buy drugs at an enormous discount, sometimes 60%. And then they can approach patients who have Medicare or good commercial insurance, and they can bill the insurance company at a much higher rate. And then they can pocket the spread, pocket the difference. That's what's called arbitrage. They're arbitraging the discounts, buying low and selling high. So it's not a savings program, it's a discount program. It is a revenue program. So this is an important slide talking about the growth of the program. In 2010, the Affordable Care Act expanded the program enormously. So you'll see in this slide that in 2009, there were only 815 contract pharmacies participating in the program. And by 2024, there were 44,000 pharmacies that had contracts under this program. And the number of covered entities, same story. The Affordable Care Act expanded eligibility for the program, and it went from 4,000 in 2010 or so to 14,000. And it's the Affordable Care Act changed the program dramatically. Finally, let's look at this disturbing slide, because in 2013, the 340B hospitals were giving out 4.34% of their operating revenue in charity care. And despite the fact that you'd see enormous growth in the number of covered entities in hospitals and the number of pharmacies on the bottom, the charity care numbers declined dramatically to 2.19%, a 50% reduction despite the fact that 340B revenues were growing enormously. So this is a troubling slide, and this is one of the things we were asked to look at. So 340B hospitals get enormous financial benefits. So according to the Senate Health Committee, they get $28 billion in tax breaks because of their nonprofit status. And a back of the envelope guess is that they make $40 billion from the 340B program in revenue. And they also, most of these hospitals are dish hospitals, meaning they get a higher Medicare reimbursement when they're treating low-income patients. So that's probably worth $5 billion. So there's billions and billions of dollars that are going to these 340B entities. And again, charity care continues to decline. And I'm going to turn it over to Robert, who is going to explain how.
All right. So when Kim and I had that infamous dinner in New York, actually, and we talked about this, I came to Bill and said, look, Bill, what do you think? How do we tackle this issue? Because the main problem is what Kim is telling us is that patients are showing up to the hospital and they're not being taken care of, and we thought about it. And fortunately, we have a database that we purchased from RAND Institute, and I'll go into how does RAND get to this data. And we said, why don't we look at and compare 340B hospitals to non-340B hospitals? That will give us a better understanding of whether or not 340B hospitals are doing more than these for-profit institutions. And we went ahead and looked at the RAND data. And what RAND does, by the way, the data that they get is through CMS. So every hospital has to report this data to CMS. All RAND does is gets the data from CMS, cleans it up, make sure that there are no outliers. If there are outliers, they go back to the hospitals to have them re-report the information. And then they sell it to different people, like research institutes like Pioneer. And the parameters that we'll cover are just some of the parameters. It has about 600 data points that they cover and they collect annually. So we haven't even scratched the surface of how much data there is in this system. And fortunately, they do it for all hospitals. So they do it for both 340B hospitals or non-340B hospitals, including for-profit and non-for-profit hospitals. By the way, all the data that I will show you, we've sort of pressure checked this information because Bill and I were concerned if we put the data out there without any kind of reassurance that what we're seeing is actually what is happening. So we went to the Federation of American Hospitals. Who are the Federation of American Hospitals? They represent for-profit hospitals in this country. So we went through the data with them, and they said, this is exactly what we've been talking to Congress about for years, and this is exactly what we're seeing too, but nobody wants to listen to us. Their point of view is more from a for-profit versus non-for-profit. Our point of view is obviously from a 340B versus non-340B, because it's important to note that just because you're a non-for-profit, you don't necessarily are a 340B hospital. The biggest hospital chain in California, or the hospital system in California, is the Kaiser Hospital System. Even though they're non-for-profit institutions, they are not 340B. They're non-340B hospitals because they just don't take Medicaid patients as Kaiser, so they don't qualify for it. So the study was really comparing those two entities, 340B, non-340B, with regards to charity care for the uninsured, charity care for the initial estimation of charity care that they provided CMS, unreimbursed or uncompensated care, which is a new parameter we looked at, and then finally just Medicaid admission days. So we didn't look at the admission rates. What we looked at is what is the share of admission days for Medicaid in these institutions. And we pulled the data in May 1st of 2025. Again, it's important to note that because RAND updates this data annually. So if you pull the data now, it may look a little bit different, but just because there's differences in the reporting right now. But we had to do it. By the way, the research is available on a pre-publication website. With CancerCare, we've submitted it for peer-reviewed publication. It's going through the review process right now through Inquiry, which is a sister publication of the American Journal of Managed Care. So we're trying to get it through a peer-reviewed publication. So what does the data show? Over 1,500, sorry, 1,300, and my eyesight is going. 1,300, yeah. It's 1,500, over 1,500 non-340B hospitals, over 2,400 340B hospitals. That's important because this is a good number of institutions that we can look at. It's a representative one. And one of the other things that we found out through this research is that everybody talks about 340B institutions as being monolithic. They're not. There are categories within the 340B institutions, right? Hospital systems. There's the DISH hospitals, but then there's the critical access hospitals, the sole community hospitals, and as well as rural referral centers. Now, the three entities, the critical access, sole community hospitals, and rural referral centers make up about half of those 340B institutions. And that's important because you will hear quite a bit from policymakers, especially in the state level, when you go and talk about 340B. They say this program is so important for our critical access hospitals, that they would not exist if this basically program went away. And I'll show you some data that they're not doing enough. And one of the things that I always push back for the policymakers is to say, if they are in fact in areas that are so underserved, and there's so many people that really require these hospitals, they should be doing more, not less than the for-profit institutions. Because remember, non-340B hospitals not only don't get the revenue for 340B, but they also provide taxes, like Bill mentioned. They provide federal, state, and local taxes. So there's a lot. If anything, they should be doing more than these institutions, and I'll show you the data. And the other thing that we did is that we looked at NCI hospitals. We wanted to see if there's any differences in NCI hospital designations. And this is the number of hospitals that are non-340B and how many of them are designated NCI. Now, let's get to the data. Charity care, without a doubt, institutions that are non-340B do more charity care in total than 340B hospitals. On the surface, it should not even be equal, right? They should be doing more. They have this revenue that's coming to them from the 340B revenue, plus they're not paying any kind of taxes. They should have more resources to put towards charity care. But no, the non-340B hospitals are actually doing more. By the way, this is exactly what the American Hospital Federation told us. They're seeing the same exact data year over year. And when then you break it down, you see that these critical access hospitals, the rural referral centers, and the sole community hospitals actually do less than the disproportionate share hospitals. Disproportionate share hospitals do less than non-340B, but those institutions, especially the critical access hospitals, do significantly less. This is important, again, because the whole argument for these critical access hospitals is that they exist to serve underserved communities, and they're so critical, so why aren't they doing more for those communities that they supposedly serve? The other question that we had was whether or not larger hospitals do more than lower, like smaller revenue hospitals. And both in the DSH and critical access hospitals, the larger hospitals in those institutions, which from a revenue standpoint, do less as a percentage of their revenue in charity care compared to the smaller hospitals. So in fact, the large hospitals, and we can get into it more in detail, large institutions in states do less charity care than the smaller institutions as a percentage of their revenue. So all you hear from these institutions is the dollar amount. And that's true because they are multi-billion-dollar institutions, right? So obviously they're going to do more from a dollar standpoint. But when you look at the percentage, which is the right way to look at it because it levels the playing field, they're doing less. So large hospitals are not doing their share either. With regards to uninsured, again, non-340B hospitals do better, and same pattern follows with regards to the final charity care numbers regarding uninsured patients. Regarding initial obligation, because institutions have to tell CMS initially how much they anticipate providing in charity care, and then they give the final numbers. Again, non-340B hospitals do better than 340B hospitals. Same exact pattern with regards to the distribution between critical access, rural referral centers, so on. The new parameter that we looked at is unreimbursed or uncompensated care. Again, this blew us away because non-340B hospitals actually do more uncompensated care and more unreimbursed care than 340B hospitals. Again, it doesn't make any sense. They have all this revenue coming in, what we talked about $80 billion in revenue. Even if you say they net out about 40 billion, all this revenue coming in, paying no taxes, and they still do less uncompensated care. Same pattern, again, you see it, it's much closer, but again, critical access hospitals are not doing their fair share. Now, one of the parameters also we looked at was Medicaid, because what we were hearing from Kim and her colleagues is that patients with Medicaid were showing up to these hospitals and we were telling go somewhere else. We're not taking any more Medicaid patients in our institutions. And it is true, if you look at 340B hospitals, they take a lot more Medicaid as a share of patient days compared to non-340B hospitals. But look at what happens when you break it down. It's really driven by DSH. Why? Because it's a requirement for them to be eligible for 340B, because then they have to take a certain number of Medicaid patients. There is no requirement for a critical access hospital. Look at the percentage. It's only 8.4% of the patient days, compared to the non-340B hospitals, about 18%. So again, institutions that are for-profit are doing more. They're paying taxes. They don't have the revenue cycle, and they're doing more. And again, no different than what we've heard about. So in summary, basically, except for Medicaid, share of Medicaid days, everything else, non-340B hospitals do better than the 340B hospitals. Critical access hospitals fall significantly short. And frankly, the financial benefits are not reaching patients at the point that we need to. We keep talking about critical access hospitals, how important they are, and they are important. But then they should be doing as much, if not more, than for-profit institutions. With that said, I'm going to turn it over to Kim.
Thank you, Robert. And I do want to encourage everybody online to don't wait until the end. We will have an opportunity for Q&A, but we encourage you, as you think of questions, to please put it in the Q&A now, and we will get to those towards the end. And again, during the Q&A for people here in person, please jot down your questions and remember them so we can make sure to address them at the end of our presentation. And I didn't know, just for a moment, Robert and Bill and Pioneer Institute provided that data analysis that CancerCare reached out to them to do. Our focus on the project from CancerCare's angle was to humanize 340B. So the data, as we all know, is extraordinarily important, but it also, as many of us know that work in the policy space, is that in order to really make change, you need to have data, and you also need to have the patient stories. So CancerCare's role in this, and why we approach this, is we want to make sure that these patient voices and patient experiences at 340B hospitals became known and became the forefront of what the program was meant to be. So again, I know Bill and Robert mentioned it, but the intent of 340B is to stretch scarce federal resources as far as possible, reaching more eligible patients, and I'm going to focus on these words, providing more comprehensive services. Very important. Was that being done? And as we heard, it is not being done, at least overall. And the intent is meant to be achieved, as Bill had explained, by 340B participating hospitals using the savings they get from the purchase, creating revenue from that when they go ahead and sell these drugs to people with commercial or Medicare, and then using this revenue that's generated in order to provide this charity care and uncompensated care. And again, let's highlight always as we discuss these patient stories, the intent of the program. We don't want the intent to get lost in all the numbers. The intent of the program is to benefit low-income, uninsured, and vulnerable patients. So what did CancerCare do in order really to capture these experiences? And I have to really credit our social workers. It was a very difficult task. We identified patients receiving care across the country at different 340B hospitals that would be willing to speak with us and share their experiences. And I will just note that it's just the environment now with people with Medicaid and people who feel their insurance status is not secure, that many people are reluctant, even though we assured them they wouldn't be identified, many people are reluctant to share because it's just some challenging times. So we appreciate greatly the efforts on our social workers, but also those patients who are willing to share their experiences, because without those patient voices, we wouldn't have what I'm about to speak to. So I did want to speak to, there are, for those in person, there is a resource here on your table. This is a resource that CancerCare has developed that captures some of these patient voices, and I would like to go through them, but they each touch on a different aspect of 340B and charity care. So one patient, first quote is, "The 340B hospital I was using gave me 2 $25 gas cards. That's all they give you. I switched hospitals now to a non-340B hospital, and they're paying me for my travel, and it's quite some, it's some distance." That goes to that comparative element. 340B hospital providing $25 gas card, but the non-340B hospital picking up the entire person's cost of transportation. And as we know at CancerCare and as our social workers here every day, travel to and from to get care is a major burden for people. We often take for granted that people can hop in a car. Many people do not have a car. Currently now, and it's not only now, of course, the price of gas is even added for those that do have a car. If people are using public transportation, it can be hours away, having to change lines or buses, so travel is a real impediment. Another patient quote is, "Everything was like, you just have to figure it out. Be prepared to pay. If I could pay for this visit some thousands of dollars out of pocket, why on earth would I have Medicaid? It was just so unempathetic and disregarding." The importance is the transparency and accountability that's lacking. CancerCare and Pioneer Institute and others, everybody that we are working with in the policy space, I've not heard a single organization say we want to get rid of the 340B program. And I think that's very important to say up front, to allay that fear that we're trying to get rid of that program. In fact, we want the program to work as intended. It's a very important program, and it needs to serve those that it was intended to serve. Another quote is, "I thought the most they were doing was all they could do, like the $25 gift card they gave me. I thought that's what they said. That's all they had left in their budget to give me. Seeing a theme here on the $25 seems to be the going amount that 340B entities are willing to give to patients. Next, and as you know, CancerCare again and other organizations that work directly with patients and caregivers know that the cost of food, I mentioned transportation, but the cost of food, rent, utilities, all of those things when you're going through cancer treatment become exceptional burdens and very, very difficult to manage. So this next quote that states, "My prescription drug cost was more than I expected, so it came out of my food budget." This is real. This is a real person experiencing this, and certainly they are not alone. Next, I have to pay for a lift and put that on a credit card, which I can't even afford. I don't have a job. I can't even pay the minimum on the credit card right now. So Americans really struggle, as we know, to afford the cost of their health care. And in 2024, about 31 million Americans borrowed money to pay for their health care. And that accumulated to more than $74 billion in medical debt. So if the 340B program was working as intended, we would not have $74 billion in medical debt by people, which is more evidence other than not that specific data, but that's a statement in and of itself that the program is not working as intended. Share some more quotes here from patients. One medication came out to around $50, another $20, and another $15. I don't even have $5 to my name. I asked, "Can you give me a voucher or something?" And they said, "No, you either need to be readmitted or find a way to pay for it because we can't give it to you." Now let's just stop there. There's so much in that quote. One takeaway I don't want to get lost is be readmitted. Well, what is the cost of being readmitted versus assisting a patient in getting the medication that they need? We know hospitalizations overall are the true more of the driving cost of medical debt and expenses. Next, they say, "We're so sorry. We thought this medication was covered. It looks like something's changed in the system, so you're going to have to pay for it. Or else we're going to have to give you something else and hope that it works." That's just the end of that quote is just mind-boggling and should be concerning for everybody. So recently, the National Consumers League did a study, and they found that 340B entities are more likely to take legal action against patients for unpaid bills than non-340B hospitals. Again, let's keep in mind the purpose of the program is to help uninsured, lower income, and underserved patients. And yet when those patients can't afford the care, they're more aggressive in going after their debt. One patient shared with us, "I wouldn't even pick up the phone if it's a number that I didn't recognize because it was just like collection agencies calling and they don't care." So what do we need here? Federal reforms are absolutely necessary. Accountability, transparency, we'll get into some specifics on the recommended policy forms that Pioneer Institute and CancerCare recommend, but clearly the program as it's working currently is not serving its intended purpose to benefit patients. Some more final quotes here. "I finally got my medicine from the lady that worked at the pharmacy who gave me 3 email addresses. She said, 'Try these 3 companies. Sometimes they give people grants.' And that was how I got my medicine. Nobody at the hospital." No, financial assistance or charity care from the hospital directly, no. The hospital hasn't sent me anything. The only thing I've gotten is through CancerCare. So these 340B entities are collecting this revenue. Data shows they are not providing the charity care levels equal to non-340B hospitals. CancerCare we are here in existence so we can help people in need. However, 340B hospitals are making tremendous money that they're supposed to be using to help people in need. And while certainly it is our mission to help those in need, and we're glad they reach out to CancerCare, it shouldn't be that these hospitals are sending patients in need to CancerCare and not using their money for charity care as they should be. For those in person, have this resource that we've made. Here's a QR code, one of the resources that we've made along with this project. It lists the quotes that I've just said, also lists some policy recommendations and a little bit of background on 340B. I also want to share that we are also preparing a document, a simple document to help empower patients. It'll be a one-page, and we don't want to burden patients, we want to empower them. So we will be providing a little bit of background on 340B, what it is, why it exists. The intent of this resource will be to encourage patients when they go to a hospital, ask upfront, are you a 340B entity? It may be that the person you're speaking with may or may not know, but we have one recommendation that should solve that. So once they get that answer, if they say, yes, we're a 340B hospital, and if they don't know, ask them to go to somebody else to ask are you a 340B hospital? And once you get that, ask, can I please have the contact information for your financial assistance program? I would like to have that. So that's how we can empower patients. There's a lot to happen on the federal and state level. Again, we need federal reforms, but we're trying to navigate all the different reforms. The lack of federal clarity has caused a lot of activity at the state level, but we also want to make sure that patients start to know about this and push the envelope a little bit with hospitals. And now we'll turn it and make a group discussion as far as the policy recommendations, and I'll turn it over initially to Bill and then to Robert.
Yeah, one of the first policy recommendations we have is to return to the original statute as far as eligibility of hospitals. And the original statute said 11.75% of your patient base needs to be Medicaid. And if that's the case, then you qualify. Why 11.75%? The answer is never look at how the sausage is being made. 11.75% was the standard, became the standard in the statute because it qualified the University of Utah Hospital, Orrin Hatch, and the University of Virginia Hospital, Tom Bliley. It qualified both of those hospitals for, and they were trying to get Republican support for this 340B statute. So the 11.75%, but that's held up pretty well because as you've seen from the data, the DSH hospitals that qualify under this Medicaid statute, they provide more charity care, more unreimbursed care than critical access hospitals or rural referral centers. So it's clear that these DSH hospitals are in poorer areas and serving more poor patients than some of these other entities that have gotten in. So that's the first. I'll turn it over to Robert for the next one.
So the other thing is that, because we know how much charity care nationally and on the state level these institutions on average provide, and we know that uncompensated care and unreimbursed care. But what we haven't shown you, and this is where we have the data from Pioneer that you can look at it, is that the largest institutions don't meet those numbers. When you go to every state, and the largest institution in the state, for example, whether it's the University of Minnesota in Minnesota, or NYU Langone in New York, or in California, Stanford, they don't even meet the average charity care of the state, and they're far below the national average. So what we're saying is that, okay, if you want to play in the sandbox and be a 340B institution, you need to at least meet the standard of national average, if not higher, and you should definitely be higher than the non-340B institutions in your state of doing these things. So that's one of the other things that we recommend. We want to make sure that there's a definition for charity care. There is no standard definition of charity care, and Bill always talks about, you can basically pass a bunch of flyers at a health event and call it charity care. That's not charity care. We need to have a better definition. It needs to come from the federal level of what those definitions are. Something that doesn't make me friends in my pharmacy circles is basically my thing is if pharmacies, which by the way, the contract pharmacies landscape, almost all of them are for-profit institutions. These are CVS's, the Walgreens, the Walmarts, the United Healthcare, Express Scripts. These are the large institutions that manage about 80% of the scripts that go through 340B. If you want to be a 340B contract pharmacy, then you should be mandated to provide back charity care to the institution. That's going to be critical because they're not. Right now, they're not mandated to do any charity care. And these are for-profit institutions that are benefiting significantly from this. I mean, Bill and I have taken a look at some of the contracts that these people have, and it's like 16%, 12% of the WAC price of the medicine. So when you're dispensing a $100,000 drug, you're getting paid about $1,200 in dispensing. So one of the recommendations we have actually, and Bill can talk about it more about transparency, is that perhaps what we should do, and we always say this when we testify in the state, is that these contract pharmacies should be getting a dispensing fee which is equal to the Medicaid dispensing fee in the state, which is a flat fee of about $11.50. And you will quickly see how many of these contract pharmacies drop out of the program because the revenue is not going to. Bill?
Yeah, in my view, the first step towards reforming this program is some transparency, because hospitals now do not report on how much revenue they take in from 340B program, and they do not report where they spend it. And in my view, hospitals should be required to report how much revenue they get, and it should be deposited in a separate account. And so it could be audited where they're spending it. And right now, it just goes into general revenue, and it could be spent on executive salaries or anything else. We don't know where it's going. It's very opaque. And as Robert said, they also should be reporting on how much they pay contract pharmacies. Right now, we don't know any of that. And some of these contracts are very generous and very confidential.
Yeah, so I mentioned trying to empower patients with another resource that we'll be creating. And this really gets to the last policy recommendation here. Many of you may be familiar with the No Surprises Act. For those of you that aren't, it is really to protect patients when you go to get a procedure done or care at a hospital that is in network, but then you find out after the fact that an anesthesiologist or somebody else that worked on you and provided your care is not in network, that you'd get a very large bill, and hence a surprise. Actually, it was very surprising and very burdensome for patients, a tremendous medical debt, as that number referenced before. So the No Surprises Act requires that when people go to a hospital, they are provided a standard statement of what the No Surprises Act is, and explains them what their rights are, that they can't be charged for out of network prices because they're at an in-network facility, and I believe you sign the document. So are they experts in the No Surprises Act? No, but they're put on notice that there's something in place to protect them. So when those bills do come later, they have an eye towards that and say, wait a minute, something doesn't line up. Why am I being charged so much for this expert or this provider? So much like that, taking from that, there should be a standard notice. We can all agree on the language, but there should be a standard written notice given to people at hospitals saying we are a 340B hospital. What that means is X, Y, and Z. And here, very importantly, here is the contact information for our financial aid assistance and office for you to contact. Again, will the patients become experts in 340B? No, nor do they need to be. But they do need to know that there's a program out there that's designed to help them, supposed to be giving them charity care and focus on their needs, and nobody knows it. And again, as I mentioned, maybe people at the hospital they talk to might not know it. But if we can align on this, they can take that away, hopefully beforehand and after, and know to empower themselves to reach out for assistance. I will share that when we were reaching out and identifying these patients that we got these quotes from, they were, as I mentioned before, they were challenged, and many people were unsure to speak with us. Initially, as a recovering attorney, I started off my questions to these patients, and with the 340B is this and that, and this is how it originated, and brought down to earth, appropriately so, in a very kind way, by my social workers who, speak every single day, every week, 800 to 1,000 calls with people, and said, you're going to lose them right in the beginning. So I rearranged the order of those questions, really asked in a different manner. I didn't put together the questions, and the social workers, our final product is 340B was not mentioned until the very end of our discussions with these patients. And that last question was, there is a program, 340B. We briefly explained how it worked. And we said, if you had known that this program existed, would you have reached out sooner, or would you have reached out at all for financial assistance? And they all said yes. So that was very telling, and therefore we think the standard notice would be very helpful. Did want to share one other mention of another aspect that we'll be doing that I failed to mention before, is from some of these patients that were gracious enough to speak with us, we'll be putting together 2 or 3 videos. They're willing to come on camera, we're very, very thankful for that. And we'll be using those videos in our policy and education work. They'll be shared on social media, on the website. So again, we think it's so important to have a human face on 340B, because that is what the program is for. So we'd love to open it up to questions. Again, please, those of you attending virtually, please put your questions in the Q&A. My colleague here, Johnny, will be reviewing those and picking them up and sharing them with us, since we don't have a screen right in front of us. And those of you in person, please raise your hand, come off, their speakers at your desk, and we'd really like to have an engaging conversation. Thank you. Yes. Oh, please identify yourself.
Sure. I'm Thomas Johnson, Executive Director at ASAP 340B. And I probably have more of a comment than a question. I think I am increasingly impressed by the number of patients and consumers that I speak to when I speak in front of groups that want to know if their hospital is a 340B hospital. I would say probably in the last year, half of the churches or consumer groups that I've spoken to, that subject comes up. And I've actually started to say, well, maybe you should ask them if they're a 340B hospital. And so, I'm really impressed with the recommendation about the standard notice, because I think that's a direct way in which, consumers can participate in making sure that hospitals are aware that they're becoming more and more aware of the 340B program. And I think that, hospitals will listen to that. So, I think that's a really great recommendation.
It was a very opaque system before. I mean, patients never heard of it, didn't know to ask. And as we all address, the federal and state level, and try to work our policy magic and get reforms that are needed, we need to empower the patients to start speaking up, because that's the way the hospitals, I think they'll take notice of that. And they can't, they can't hide behind numbers and something that they think most patients have never heard about.
And Thomas, let me add to that by saying, one thing I'd like to see happen, and it's not going to happen overnight, is that with federally qualified health centers, some of them give a discount card to their patients. And they can go into the pharmacy and access the 340B discount with that card. And I'd like to see hospitals do that. I don't know of any hospitals that do that. The clinics, which tend to give out more free care and more discounted care, the clinics, I've learned, do this on occasion. So I'd like to see hospitals do. Then they'd know, the patient would know the hospital is getting a 60% or 70% discount on my drug, and I can access that.
We have a question online. Are many of these 340B hospitals using their surplus revenue to add their names to things like stadium, etc., or does this come from separate budgets? And second, what happens to things like mobile clinics?
Well, the answer is money is fungible. So we don't know if they put their name on a stadium, whether it's coming from 340B, because the money from 340B goes into the general revenue. And I would like to see it deposited in a separate account, so that if they wrote a check to SoFi Stadium and change the name of that to Stanford Hospital Stadium, that we would know where the money came from, and it would be 340B. Right now, we don't know any of that. It's all opaque.
What was the second?
What happens to things like mobile clinics?
Well, I mean, that's unknown, right? Because we don't know how much, again, of the money is supporting mobile clinics versus mobile clinics like an independently funded organization. So what Bill's saying, if we have a better idea where these budgets sit, then we can say, yes, it will impact mobile clinic or something else.
And our mobile clinics, the question is are they charity care or are they marketing?
Yeah.
You're going out into the community. Are you getting patients to be admitted into the hospital? Is that really charity care? We don't know.
Or are you managing blood pressure, for example?
And again, those doing the right thing and really doing their portion above and beyond, this is an opportunity for them to show that, and they should shine and be applauded, actually.
Hi, my name is Christy Gupton, and I'm actually an employee benefits advisor, but I entered my career as a registered dietitian in the WIC program, so I have a public health DNA in me. But I think it's important to go a step farther, Kim, with your recommendation on notice of a hospital's financial assistance policy. I think those policies really need to be standardized across the country. There's too much latitude that hospitals have in writing those FAPs. For instance, I read the hospital FAP that is down the street from my parents, and it just happened to be at a time where my dad had a great little part-time job at Costco, and that he loved. And they were both on Costco's high deductible health plan. So their hospital just basically said, if you have employer sponsored insurance, you are not eligible for our financial assistance policy. And that's just that's not right. There should be more standardization. Hospitals shouldn't be able to game Internal Revenue Code 501R, where that charity care program originated, also with the Affordable Care Act. They shouldn't be able to game that at the community level. There should be some more standardization. So if hospitals want to access 340B, then they should be able to say we have a certain, minimum threshold of writing off of patient care. And then the other thing I wanted to point out is about uncompensated care and how that is calculated. So if you push forth an opaque billed charge that is, exponentially higher than what they submit to CMS in terms of what that care actually costs them to provide, and then you subtract that from the actual payer, the way that claim was paid, and the difference between those two is considered uncompensated care. That is an arbitrary and capricious transactional, like that. Someone needs to hire a forensic accountant to help explain how uncompensated care is actually come up with and bring some truth and transparency to that.
And you're going back to the main recommendations that there are no definitions. There are no definitions of charity care. There are no definitions of uncompensated or unreimbursed care. Some of them put bad debt as part of unreimbursed care. Or now the terminology has shifted to under reimbursement. So the biggest thing that Bill and I, when we go testify, well, the Medicaid program is not paying us enough. Therefore, we need the 340B program to backfill under reimbursement for Medicaid. Well, no, go fix Medicaid. Two wrongs don't make a right,
But let's also go to either CMS or the American Hospital Directory and find how it is they reported their costs. So in claims data for a client that hired me to look at their employer-sponsored claims, we found a $30,000 CT scan in the claims data, a paid claim. The billed charge was over $100,000. When we went and tracked back the source data to where that hospital reported to CMS their cost charge ratio, it says that it cost them $800 to perform that CT. So there's just such a gaming of the of every part of the supply chain of a claim.
Exactly. And that's how they sometimes, what we notice in the data is that they calculate unreimbursed care as in like, yeah, I charged 30,000, I got reimbursed. My contract number was 800, but I believe I should have been paid 30,000. So the difference is unreimbursed care. That's not unreimbursed care. You had signed the contract for $800, just not happy about that. Now you can game it and put it as unreimbursed. You're absolutely right. Bill?
Is this thing on?
Yeah.
Joel White, Council for Affordable Health Coverage. Thank you for doing this report. Thank you in particular for focusing on the cancer stories. I think a lot of times we lose the patient focus here in DC, and we talk about numbers and financing and eligibility and claims and things like that. So thank you very much for doing that. An important report. I guess I have many questions. I have three maybe that are quick ones. So the first thing is on reimbursement. Nothing here on the reimbursement side. I know like the Trump administration talked about maybe lowering Medicare reimbursement. If you buy low, get paid low, right? And you're getting the lower input cost. So that's kind of question number one. Why nothing on reimbursement here? Second question is, how hard would it be to get to a claims-based identifier so that we would know with specificity which claims are 340B drugs, and then maybe get to a reimbursement system? And then third thing, and just very quickly, the Trump administration proposed and then withdrew and is RFI out now for moving from a discount to a rebate model. Do you have any thoughts on that?
So let me address the rebate versus discount, because when Bill and I started on this project, we actually worked a lot with this company called Calderos. You guys are probably familiar with it. It's the original company that really introduced the thought about rebate as a way to compensate hospitals instead of what happens, which is upfront discount. And we think that it's one of the solutions that you can provide. But that requires your second question, Joel, which is how do we get to who is the patient eligible for 340B? Right now, there's litigation going on with regards to pharma companies trying to mandate hospitals and clinics report who are the eligible patients that are getting the discounts. Not every hospital is complying. In fact, there is something going on with one of the large companies right now in the hospital system. The American Hospital Association has told its members, don't comply with it, don't report, you don't have to by law. So I think we need to get to that point that who's eligible are these patients that are getting the discount eligible patients. And the second part, it will answer the question, which is now can we get to a point that, the discount is basically applying to the patient in an unreimbursed fashion, but a rebate can help out with that.
And on your first question about reimbursement, yes, the Trump administration in the first go round tried to reduce the Medicare reimbursement for 340B drugs. That's true. But I'm also noticing that a lot of other organizations are starting to pick up on the fact that they're overpaying for many of these 340B drugs. So the North Carolina Treasurer's report put out demonstrated that the state employee plan was paying 5 times what the hospital was buying the oncology drug for. I've also noticed myself that I'm testifying in a lot of Midwestern states. And when I testify in Midwestern states, employer groups approach me and say, can we sit on the panel and talk about how much we're overpaying for 340B drugs? So employers, commercial insurance are starting to pick up on the fact that they're overpaying for drugs.
Just share here as well that oncology drugs make up about 41% of those in the 340B program.
Mm-hmm.
Those are particular importance. And, why? Well, oncology is an expensive disease to treat. So they're just, maximizing, and other data is out there The 340B hospitals are marking up their cost of the same drug 150% times more than the non-340B entities. So it's, yes, there's the arbitrage. Yes, if it's used properly, it can provide that charity care. One, it's not being used, but also 340B hospitals, many of them are charging greater percentages of, you know, increased cost than non-340B hospitals. So all the way around, the system is being gamed.
Tim, when you said
Thank
41,
you.
I have a question about the 41% actually. Is that the utilization, the number of scripts are oncology drugs, or the revenue from it is oncology? Because it may be the revenue may be significantly higher. I think that may be number of scripts.
I don't know. I'll have to check back on that.
Yeah.
I'm not positive. I just know out of all the different classes of drugs, oncology makes up about 41%. I don't know, maybe, I don't know if Thomas knows the answer to that. Okay.
Scripts. I think the revenue is going to be
Be
significantly
much higher,
more
yeah.
because of the expense of these
Yeah.
scripts. Sorry.
Just to thank you, our perspective is that this is driving up reimbursement, is driving up cost, and that those are getting fed through to premiums and out-of-pocket costs and making things less affordable for consumers, which is our focus. So thank you for doing this.
I want to add an online question. In today's increasingly volatile reimbursement environment, many cancer programs feel significant financial pressure from declining reimbursement, rising costs, and administrative burden. For organizations that view 340B as one of the few mechanisms available to help offset these challenges, what would you say to those leaders who feel their ability to sustain oncology services depends on the program?
Look, I would say the same thing I tell people when they say Medicaid is not reimbursing enough. Fix the problem. If you're burdened by prior authorizations and that's driving your administrative costs higher, then fix the prior authorization problem. Don't try to make corrections through the 340B program. If you're feeling that you're being undercompensated for cancer, or you need more resources for cancer, fix the problem. Two wrongs don't make a right, and that's what we're doing here. We're trying to, and we see this, but by the way, it's not just 340B, right? Bill and I have been in the state Medicaid business for a long time. They use a lot of Medicaid. Medicaid rebates in most states are not used to cover healthcare. They're going to the general fund, and they're basically, as we say, filling potholes and underfunded programs in the state level. Again, the money is there. Fix the underlying problems that are causing that.
Any final questions or anybody else online?
One more from online. Does Pioneer Institute have a working definition for what should qualify as charity care?
Bill?
The answer is no, nobody does. CMS doesn't, IRS doesn't, nobody does. It's a very slippery concept. And because the data is self-reported by the hospitals, I think there's a lot of monkey business that's going on, but I can't be certain of it.
So we do need a definition. That's what we
Yes.
all agree on. It needs to be a federal one, not a state level one.
Well, thank you all. We appreciate it. We're certainly happy to share the slides. Oh, sorry, that's not going to work for that. So if you have any questions, please reach out to either any of us here on this panel. Here's our email addresses. Happy to share the slides and engage in this discussion. We hope it doesn't end here. It can't end here because the problem has not yet been solved. So we really would like to join forces. We'd like to get in discussions, bring all the stakeholders into this discussion, and let's figure out a way to make this work. Because the changes that are happening, whether it be in commercial insurance, whether it be in Medicaid or Medicare, they're happening as we speak, and they've been happening. We need to fix the problem. As Robert said, the money is there. It needs to be used appropriately. And if there's other issues that need fixing, well, let's work together and fix those. But this program had a certain intent, and it should stay true to that intent. So thank you so much.